And I would like everybody to bear with us. Please send in as many questions as you want. And we have a wonderful faculty of speakers and chairs, and we're going to move to them to take questions. We have a list that's ever growing, and I hope I can just ask some of my colleagues to pose some of the questions. So maybe if I turn to you first, Richard, do you have any question for your speakers?
Yes, there was a question for Jenny from the audience about equality of uptake of the Mhealth app. Do you have any data or any insights from the clinical services? Because you made a really important point that this is not for everybody, it should be a choice. So do you have any insights on who's making that choice?
I think it's fair to say, Richard, that it's very variable. So we did look at this as part of the study. I think it's important to say that age wasn't a barrier. So the oldest person using the app in the study was 84. And I think there's often a perception that older people don't get on as well with digital, but that obviously is very variable. Lots of people were concerned about privacy and security, and where people share apps in families or where kids can have a look at the app, there was concern. And we purposely co-designed everything so that it was very neutral, very innocuous, and couldn't be easily recognised around that. People, it's just choice really. People were worried about not seeing their clinician, but many people really saw it as an opportunity to come less frequently and to avoid stigma. So yeah, a really varied response, but some quite rich data around that.
Thank you.
Thank you. Bruno? Do you have any questions for your speaker?
Yes, I have plenty of questions for the speakers. The talks were very interesting. I had a question to Michel. I'd like to know what if you think that COVID-19 situation can kill democracy.
Thank you, Bruno. What a question. There was another question similar, almost similar to that, which I have seen in the chat about how much the COVID-19 response has been top-down as opposed to the bottom-up pattern of the HIV response. And of course, that's inherent to the fact that COVID-19 has been such an emergency. The very characteristics of this virus is the speed at which it is being transmitted. So all decisions have to be made in a sort of emergency situation. And people didn't quite know what to do. People have been, in most countries in the world, except some Asian countries, on a wait and see attitude for several weeks. And then the emergency sort of took over. I'm not justifying here the top to bottom approach. I'm just setting the context in which it took place. Now, of course, a year later, what we're seeing is that the top to bottom approach is still there, although we're moving from emergency to endemicity. And in a number of countries, we've seen that authoritarian regimes have used the power they took to restrict freedoms as an opportunity to expand, to restrict freedom beyond what maybe was needed, and to install somehow their and consolidate their authoritarian regimes. So I don't think COVID has been helpful to democracies. Whether it will kill democracies, I do not think so. I'm confident that democracies will take over and come back strongly. One of the driving powers there will be the civil society. But the civil society in the COVID world is not the same as the civil society in the HIV world, because once you've out of COVID, you're out of COVID. You're not living with COVID like you're living with HIV. So to me, somewhere advocacy around COVID, if I was to draw an analogy, is closer to what we're seeing in TB rather than what we're seeing in HIV. I see Lucy on the screen. I don't know how much you share that view, but that would be my answer, Bruno.
Thank you.
Any comment, Lucy?
I was just thinking of the evidence that we've seen on long COVID and how that might, and I think we just don't know enough yet, but how that might have some more parallels to the long-term impacts and long-term survivors. But how strong that lobby will be, and I think one of the strengths we've seen of the HIV lobbies have been that they've been population groups. Whereas, long COVID doesn't seem to affect particular population. It's very hard to know how that will translate to the kind of advocacy that we've seen or not.
I agree. And I fully agree with you that there's still a lot we have to learn. There are now papers saying that it's like 1 in 3 of the people who have COVID who end up with some sort of longer term symptoms. Whether that will turn, I mean, I'm familiar with some NGOs now in the UK and in some other countries, bringing together people with long COVID, but that's more like a forum for and building some sort of group rather than, lobbying. Where I see the lobby and where I see the powerful movement is really in the inequity around vaccines. And that's where I would draw the parallel with HIV. And we've seen the head of UNAIDS actually taking the lead on the People's Vaccine Campaign. To me, this is a sort of a place where the movements can join. We, the HIV movement, have been fighting for access to all for medicines. The COVID pandemic is not a pandemic that we will deal with therapeutics, but with vaccines, at least at this time. We have to join all of the effort to stop that unacceptable inequity.
Can I pick you up on that, Michel? Because we have COVAX, which is our only droplet of hope on equitable delivery. And then we've got the Global Fund. I know you're located in Geneva, and I wonder if we're going to see splintered new organizations growing to deal with this, or do you think one could imagine they would all get together and Global Fund could perhaps take some leadership because of its experience?
Well, thank you, Lorraine. Actually, they are working together. That is, COVAX is part of the so-called Act A, which is a coalition of Gavi, Global Fund, CEPI, which is incentivizing research and development, WHO. So they are working together, and the Global Fund is actually allowing, now has received significant funding from different people, including the US, almost 2 billion recently, to support countries to prepare for vaccination and to strengthen the health systems and the resilience of the health systems in facing COVID. But let me just say here, and we're in an open conversation, so I don't feel too restricted. I don't think COVAX is the right model. It is still a model, and somewhere the Global Fund as well, of the 2000s or end of 90s. A model where there is a global north and a global south. And the solutions come from the global north for the global south. I don't think that's where we are. I said in my talk that we are in a very multipolar world, it isn't only the wonderful Western industry that produced vaccines, it's also China, it's also India, it's also Russia, tomorrow it's also Cuba, and you know, Africa clearly stood up somehow and came together as a continent and said, sorry guys, we haven't been even consulted about the design of COVAX. So we're fed up with your vertical initiatives. It's time to change. And I would like to see, and that was the point I was trying to make in my talk by sort of depicting the new landscape. I think COVID is providing us with an opportunity. And I'm not saying tomorrow, because we have so much to do today for vaccines. But as we prepare for the next pandemics, to build a different system, not a system where it will be the market liberal economy that produces novel technologies, and then we have people to buy those technologies and redistribute them to the others. We really need to take this opportunity to think of collectively producing global public commons or global public goods, that is to have an end-to-end system from research and development to delivery that is exclusively public and that is multilateral and global.
Can I follow up on that, on your question, Lorraine?
Go ahead.
I was just wondering, Michel, have you seen any tangible, real example now of a positive impact of everything that happens now with COVID on HIV or AIDS policy somewhere in the world, or is it too early?
No, I don't know if it's on HIV. It's indirectly on HIV, but I was really fascinated how many NGOs. You know, I'm in the HIV field. I myself have sort of specific interest in everything that relates to drug use, people who use drugs, or Eastern Europe. So I'm a bit biased here, but I've seen extraordinary work by NGOs that helped overcome the challenges of the lockdowns and changed the delivery of methadone in countries where it was so restricted. You know, you have to go twice a day or once a day to a clinic, even if it's 10 miles from where you live, to home delivery, to long-term prescriptions. I have also seen across the world, you know, from US, Africa, Asia, Europe, authorities releasing people who were incarcerated for minor offenses from prison because of the COVID in prisons. And therefore, those countries asking themselves whether those incarcerations were justified in any way. And we in the HIV movement and all of you, you know, here, you know, at AIDSImpact, we're all advocating against the absurdity of criminalization and incarceration of people using drugs with minor offenses. And we know that this is a driving force for HIV. So if I had at least one example that comes to my mind, Udi, that's what I would put forward. And hopefully we will be able to follow up on this. So I really take this opportunity to call on everyone in the NGOs who are, you know, listening to us. Let's not have these people go back to prison anymore. And let's use this opportunity to campaign hard for decriminalization.
Caroline, could I ask you, I mean, I think what we're hearing from this discussion is this kind of north-south divide, and somebody's asked a lovely question about data. The data you've got about HIV and COVID, is the data very north-driven, or and do you see any differences according to geography in what the data you're seeing?
I mean, it is very much north driven, with the exception possibly of the South African data that I presented. Almost everything else I've seen over the last few months has been from North America or from Europe, really, particularly around HIV. And I think a lot of that does come down to the fact that the HIV clinics have got good systems in place for collecting that data easily. And they've got, someone else I think mentioned on the chat about whether we can capitalize on the systems that we have in place for data collections for HIV to sort of capture COVID outcomes as well. And I think what we're seeing is a reflection of that, and that there are systems in place that then can be used to capture information on COVID outcomes. And so therefore we don't have to reinvent the wheel, we don't have to set up a new system. And so most of the studies, unfortunately, are from, I would say, from the north. Of course, the other issue when we look further afield, I mean, there was some data I showed from China, from other areas where COVID hit very early. Of course, there you've got more issues around being able to identify who is and isn't HIV positive within a data set. I mean, there's so many other issues around collecting HIV data in those settings. So I think we are where we are. I don't know if there will be any real differences. There are, of course, issues around inequalities, access to care, exposure to SARS-CoV-2 are obviously going to be different in those settings compared to Europe. Yeah.
Great. Bridgette, do you have any, I know you're going to ask some questions, but do you have any reflections as a voice coming from South Africa?
I was just going to pick up, Lorraine, I think it was a question that was posed around COVID-19 vaccination strategies for HIV. Should they be prioritized? I think it's an interesting question and probably relates to some of the things that Michel raised as well.
Yeah, well, I mean, let me start by telling you what the situation is in the UK, because I want to put it into context here. And certainly here, people with HIV have been placed in one of our higher priority groupings on a similar footing as other people with comorbidities. And so they were put into groups that would allow them to access vaccination sooner. Now, the way that was initially planned to run had not really been thought out very well. And initially, certainly, it was through the GP, which again meant that people would have had to disclose their HIV status to their GPs to be able to get access to that earlier vaccination. But with a combination of effort from the community groups, from Viva and many others, that has been changed. Within HIV clinics, there is some opportunity for clinics themselves to put people forward for earlier vaccination without explaining the reason why. So here we are in that situation. Now should that be the case? Well, I think that comes down to whether we think people with HIV have a higher risk of poorer outcomes, and whether that's a causal one. Though you could argue, does it really matter if someone with HIV is at increased risk of a poor outcome by the nature of their job or their living circumstances? Maybe we would argue it shouldn't matter anyway. They should be at a higher priority listing. If we think about whether it's causal or not, I mean, as I said in my talk, until relatively recently, there's been very little evidence to support that one way or another. But what I can tell you today, and which unfortunately we didn't have at the time when I recorded the talk last week, we have recently presented some updated information from the BIVA COVID-19 registry, and this was presented on Tuesday this week at the BIVA Bash conference. So I can share that with you now, that we have information on 1,310 people with HIV who had COVID, either symptomatic COVID or people who were tested positive. And we did see in that an association with the CD4 count, people with lower CD4 counts and people who had a current or recent AIDS diagnosis did tend to have a much more severe presentation, and as a result of that also had a poorer outcome. So I think there is now starting to be some evidence that might also then support the fact that there is something causally associating between HIV and poorer outcomes there, which certainly the recommendations from our talk earlier this week was that people with HIV probably should be prioritised for earlier vaccination, and certainly closer monitoring, vigilance on everybody's part to make sure that people are being sort of diagnosed quickly.
Caroline, have you had any experience of using monoclonal antibodies in an HIV person that you would think is at risk and would come, with at a relatively early phase of the disease? Isn't that an indication?
I'm probably the wrong person to ask about that. I'm sort of looking at the large data sets.
I do understand, but since you in the UK have always all of the data coming at once, whenever someone asks a question, there's always an answer from a registry in the UK. So that was an attempt.
Well, it's interesting. To be honest, we didn't collect data on that in our registry. So we didn't actually ask people if they'd received, if they'd had any other treatments or whatever. So we did ask if people would have been at risk for reasons, whether they'd had treatments or things, but the very small proportion of people who actually said yes to that. So I don't think I can really comment. One thing I would comment on, actually, Michel, in response to your answer just previously, long COVID, we did ask about whether people had got the symptoms that were still ongoing after 3 months, and actually it was a relatively small proportion, and particularly in a group where, if anything, we might expect to see an overcall on people with long COVID, because people with symptoms might be the ones who are more likely to report it. But actually, it was only a relatively small proportion. I think about 7 or 8% of the cases reported having problems.
Yeah,
I think it's going to be a real challenge to study long COVID going forwards, because particularly in HIV, as I alluded to, because of the overlapping symptoms.
I agree. There are some papers with some low figures, as you just mentioned. There was one recently, if I'm not mistaken, in the New England about the cohort of healthcare workers who had COVID and who are followed up prospectively. And it was about that percentage, slightly below 10%.
Do you see any comment on adolescents? We've got a nice question here about adolescent acceptability of vaccine, but any views or perspectives or wise words?
I think this is one of the areas where, if the COVID response does not learn from HIV, that we can already see a disaster looming. We've absolutely learned that adolescents do not respond to treatment, do not respond to the offer of treatment in the same way that adults do. We've learned that adolescents don't respond to prevention services in the way that adults do. And we've learned that when those approaches are designed by adults, they very often completely miss the mark with young people. And I often think of it when I saw Boris Johnson or President Trump standing with their COVID messages, and I thought, what would that feel like to an adolescent? And it just seems to me to be an absolute outstanding, where you can see that something is coming. And I haven't seen enough of the variegated and nuanced response that we've had to learn about and are still learning about with HIV in the COVID response. I think it's essential. It'd be great to hear what others think of this, because many of you have worked on prevention work as well with young people in quite different contexts.
Jenny, are any of your patients younger? I know you've got an 84-year-old, but what about your 15-year-olds or your 18-year-olds?
Well, go ahead. So, go ahead.
I was going to take it slightly laterally. So, I think young person services across sexual health and HIV have been massively impacted, and you'd imagine that young people would be very digitally savvy, and many of them are, and digital will be a good solution, but not all of them. And I think we've been quite concerned about many of our more vulnerable young people not accessing contraception, not accessing sexual health services, and the privacy aspects at home become even more pertinent if you can't find a space in the house that you can speak on the phone or by video, whereas you could just nip out after school and pop into the walk-in clinic. And certainly, you know, in Brighton, we've worked quite hard to have text messaging services, keep the walk-in open, you know, throughout for that very reason. I'm talking more about sexual health than HIV specifically there, but I think that, you know, through primary care in the UK, there was another great talk at Beaver Bash this week around the impact that e-consults is having, and many GP services still don't have their doors open, and it's going to be a lot of backlash, huge numbers of mental health issues, you know, that we're seeing in this group who are already having quite a difficult time. So, and yeah, internationally, I can only imagine that that's even more enormous. So yeah, I think there's a big issue waiting to happen, and you know, digital has to be part of that solution, but the human touch is incredibly important, and the nuances that you pick up on in consultations, and you know, little question that you ask, or the relationship that you build that allows people to talk openly and to seek help is, you know, we risk missing that enormously at the moment.
I just wanted to point an interesting parallel between HIV and COVID in terms of prevention. I mean, if we're putting all our eggs in the basket of vaccines, and vaccinations is eligible actually at the moment from 16 on, maybe it will go down to 12 soon. And that's kind of like parallel to the coming of age paradigm that we had with HIV prevention. We actually wanted to prepare people becoming sexually active anywhere between 12 and 16 to be actually hands-on on their sexual health. And here you have also trying to persuade kids 12 to 16 also to be accepting of COVID vaccines. And that's kind of an interesting parallel and a challenge for prevention. Actually, COVID approaches can learn from our approaches in HIV prevention, how we prepare adolescents coming of age to deal with the sexuality or to take responsibility for sexual health.
Excellent. Bruno, any comments from France and from Ed? And
I have also a comment and question, and I think Michel can answer. And it's someone in the audience who asked this interesting question: is the fear that COVID-19 will reduce HIV prevention funding? So I would like to have your opinion, Michel, on this topic.
Of course, you know, across the world, the emergency response to COVID has resulted in sort of diverting some of the services from HIV, from TB, from general care to a focus on COVID. So particularly in the lung disease area, you know, many doctors in the labs, many doctors have had to go to COVID testing and so on. So we've seen, and I suppose this will progressively, but very, very progressively, come back to where it was. On the funding for prevention, we are in the current cycle, you know, with regard to international funding. The Global Fund was replenished last year significantly. I don't see any sort of short-term danger there. All of the COVID money going to the Global Fund is additional money to what had been pledged in Lyon last year. At national level, I would certainly worry. But I think all of us have to think that in the future, I doubt that we will keep those vertical schemes and that there will be a sort of safe, you know, channel that would be only specific for HIV. I think the more we move towards 2030, the more we will have to think broadly and it is for us in the HIV movement to try and, you know, and get on that move, shifting our views from a privileged situation where we were having a guaranteed income, if I may say so, for HIV, to an era where we will have to fight for funding for prevention and treatment at large, beyond HIV. Certainly HIV, TB, hepatitis, and COVID-19 once it has become endemic, which is becoming. Yeah, that would be my comment. But no threat from a global fund perspective, for sure, no immediate threat.
I wonder if I could just come in and comment on that, if that's okay. I mean, obviously prevention is one thing, and I'm sure both Lucy and Lorraine, I mean, you can comment on funding cuts for sort of academic research, but I think that's going to be a real problem many of us are also going to have to face, because the pots of money that, as Michel said, the things we used to apply for that used to be these sort of constant routes for funding, I think are going to be close to us fairly soon, because governments won't have the money to put into those pots. So we're going to have to be quite inventive for our research projects to work out how we're going to fund those studies. And certainly I think in the UK, the universities are really going to suffer in the next decade. I mean, we can see it already. But on top of that, from my perspective, as a database researcher, shall I say, someone who uses routine data, I'm now going to have to cope with these gaps in my data that I will never see those data, because sexual health services were closed, HIV services, there was no testing, no viral loads, no CD4 counts. And so much of the work that I would do routinely, I'm now going to have to change how I approach that. Many of our ongoing studies, obviously the face-to-face visits were postponed. So, we're not going to sort of conduct those studies in the same way. And I think we are going to have to rethink how we do our research projects, at least for the next few years, until we get back on track again. And I'm not sure really how many people have had the time to even reflect on that yet, because it's still just been this sort of just panic to just keep things going and, as smoothly as we can over the last year. But as we start to go back to a sort of more normal life, we are going to have to think about that. And just apologise for the glare here. We actually have sun in West London this afternoon, so.
Or once.
Bridgette?
I have a question for Jenny brought up from the audience, if you'd like me to share that.
Yes, please.
Yes, so Natasha Delgado has asked, with the Emerge project, were you able to explore providers' perceptions on Mhealth? So what did the clinicians think?
We absolutely were. So part of our co-design approach made sure that we included community and clinicians, and sort of looked at that iteratively through the project. And I would say really varied and really interesting. So as with many things, we had some very enthusiastic early adopters who jumped on board, absolutely loved it and thought it was fantastic. And the sites that we chose were led mainly by EATG. So ourselves in Brighton, Spain had been running a video conferencing service, a telemedicine service for some time in Barcelona, but the other sites in Zagreb and Lisbon particularly were invited, by EATG, and Zagreb have been incredibly enthusiastic from the beginning. Patients were asking for access to their results. They don't have a national portal at the time. Antwerp didn't. As well in Belgium. So lots of enthusiasm from people, but also some reticence from some clinicians. So a lot driven by the concept for clinicians that they needed to see people to treat them, and not wanting to miss that human touch. So in the same way that some patients still wanted to see the person that they were very familiar with and had come to know of many years and wanted to have a face-to-face visit, the same applied to some clinicians. The other factor was tariff as well. So in some settings, the clinic obviously was reimbursed for a bum on seat face-to-face visit, but also the clinician was reimbursed. So there was no provision for virtual tariffs in that setting. So that created quite a barrier to people getting on and doing this. And I think, in other settings, we know, for example, the structure in Germany is very different. And until very recently, people have been seen, I believe, as frequently as every 3 months still because of the way that reimbursement works. But all of that has changed enormously during COVID. Belgium were waiting 2 years for the Ministry of Health to change things, and it happened overnight in the end, or within a matter of weeks. So a lot of those barriers have moved, and it takes time, doesn't it? You have your early adopters and your late adopters, and there's pros and cons from both sides. But yeah, I think there's a big thing. We talk a lot about the digital divide in our communities, but we also need to make sure that the digital health literacy of our clinicians is up to speed as well, because that again creates more barriers than benefits, if not.
We have an anonymous question, but I'm going to pose it anyway, and perhaps to the whole team as we draw closer to the end of our time. Are governments, such as the UK, but generally, taking the chance and taking the opportunity to dismantle public health systems and HIV prevention and other areas? Is there a sort of political moment that we should be aware of, or considering, or fighting against?
Well, obviously the question did come in from, I assume, somebody in the UK, and pointing out quite rightly that in the middle of all this pandemic and the chaos, the government decided that they were going to completely restructure Public Health England and introduce a new institute who would deal with this as a health emergency. And I mean, the details, it was pushed through very, very quickly within a few months of announcement. And the transition period is until into this October coming. So there's a 6-month transition period. But I still think people don't really quite know how it's going to work. And there's discussion papers out there. But obviously that was a bit of a shock to those of us who were working very closely with PHE to find overnight that, and for many of those people working at PHE to find that they were going to be sort of shifted. I don't know about other countries though, but certainly for the UK, we're very worried about the changes.
I would add to that, Caroline, that beyond the UK, the government is having an impact, but it's, of course, they've used COVID to reduce their commitment to overseas development assistance, which has enormous implications for all of us on this call that are discussing this topic. I mean, that's been something that has been pushed through with questionable legality, and certainly with questionable morality. So I think that has been something that's been pushed through without any end date. We don't have a set criterion on which this will be replaced.
Lucy, there's quite a complicated question from Philip Goldman, who says that the World Bank is projecting that 143 to 163 million people are going to be thrown into severe poverty by the pandemic, defined as under $1.90 per day, which is low. So the vulnerabilities that you're presenting are only compounding as this progresses. And he asks, have we done a good enough job of addressing the combination of health and adversity risks the pandemic is presenting? And to what extent are we seeing these issues on the table as we consider a multidimensional and perhaps a multi-solver response? How can we ensure that they are discussed more actively?
It's a fantastic question, and I think really lies at the heart of some of the next steps that we're going to have to do in the epidemic response. And that's going to be making sure that the most vulnerable groups are not ignored, but that also that there is an active and forceful response to prevent the kind of long-term challenges. Avram Sherr asked about these, to prevent the long-term negative impacts that will happen otherwise. And that's true, not only for children, but also for some of the most vulnerable groups that have been raised across this webinar. And I think for Michel's, what really pointed out and struck hard was this closing of ranks and the nationalism that I think is going to be a real risk as we see going forwards. Thank you, everyone. It's been a brilliant webinar to the other speakers.
Yes, thank you very much.